Hey everyone, we're doing our weekly compilation video on testosterone. We've talked about kind of what it is this week, as well as different ways that we can use it and different types of ways to test for it and then other conditions that are affected by it. So it's time to put that all together and have this YouTube video saved for posterity. If you're new to my channel, thanks for coming in and watching this. Obviously, kind of like and subscribe if you like this video. I try and put one of these out about every week, and basically we go over what I talk about on my Instagram page, in my stories and my posts there. So anyway, let's get started. So testosterone is a member of a specific hormone family called the androgens. So testosterone and then dihydrotestosterone, or DHT, are the most common androgens that we see in the human body. The gonads are the main producers of testosterone, so that's either testicles or ovaries. And then you also can have other organs that produce testosterone as well, such as the adrenal glands. There's a little bit of peripheral conversion there too, but really gonadal production is by far the most common and the most important. Now, the gonads produce testosterone based off of kind of some kind of influence, if you will, from hormones that the brain secretes called gonadotropins. And these come out and they tell the gonads, okay, hey, let's get ready and let's do this. Now, we measure testosterone typically by the use of a blood test or a serum testing. And on average, ovaries produce roughly 4 to 10 times more testosterone than they do estradiol on any given day. So this idea that, testosterone is a male hormone and estradiol is a female hormone is completely erroneous. Hormones are equal opportunity. They don't care what, gender you are, what biologic sex you are, whatever it may be, you have hormones, they are there. So we can just kind of forget and take that idea and throw it away that hormones really care about those sorts of things. Now, there's been lots of fallacy in the way that kind of the medical literature and even medical treatment has been for patients who are seen by gynecologists that have testosterone issues. They say, well, you don't need that. Well, obviously that's not true at all. Those patients definitely need testosterone, and so this is something you really want to look into if you have any of these kind of following symptoms. So things like low sex drive, low energy, mood swings, inability to gain muscle mass with exercising, difficulty losing weight, joint pains, things like that. Those are all affected by testosterone metabolism, as well to a kind of slightly lesser degree. And then obviously when you look in terms of signs of things like excessive testosterone, especially in female patients, what you would see is things like increased facial hair, oily skin, acne on the face, acne on the chest, acne on your back, or body hair, like on your chest, around your nipples. If your pubic hair spreads out onto your inner thighs, those are all signs of excessive testosterone. Now, as a general rule, if we were to do testosterone dosing in terms of therapies for female patients, we're going to try and get around 1/10 of the respondent male dose there. So as a general rule, like I said, if we're doing like a transdermal cream, and I'll talk about this in a little bit, we're doing kind of around 10 milligrams of testosterone, or maybe up to 20 milligrams of testosterone, at that time, as opposed to the 100, 200, or 300s we sometimes even see in male patients. So anyway. So basically, and the big thing that we see kind of, or that I see, especially in my practice, I have patients come in and they are complaining about some of those symptoms that I just discussed. And, they say, well, I've seen a bunch of other physicians or other providers, and they tell me that they don't really know what to do, but I'm having all these symptoms, what's going on? And so the first thing we really have to look at is, kind of, are there other conditions that really play into this kind of low testosterone type, symptomatology? And obviously, there are a plethora of other conditions that do that. The most common things that we would see that cause low testosterone, especially in reproductive age patients, is the use of some sort of hormonal contraceptive. Now, this ties into another hormone that we talked about called SHBG, or sex hormone binding globulin. SHBG is produced in the liver and basically goes through your body and picks up kind of unbound or free sex hormones. And there's kind of 17 little variations that it picks up. Now, oral contraceptive pills specifically, kind of work on the body in a couple of different ways. One, they're creating kind of an estrogen, especially if they're combined, they're kind of giving estrogen to the bloodstream and to the body, and that's plugging estrogen receptors, and that shuts down the ovary's natural production of estrogens. Also, the combined contraceptive medications have a progestin with them too, and that kind of tricks your body into thinking that you're in the more what's called luteal phase of the menstrual cycle, and so you're not going to ovulate. So they're working on those two different ways there. Now, ethinyl estradiol, which is probably by far the most common type of estrogen, especially in oral birth control pills, has an inhibitory effect on sex hormone binding globulin, or excuse me, not an inhibitory. It goes in and competitively binds for those receptors. So what you're going to see is that sex hormone binding globulin level goes way up because all those receptors are really filled. And then the other thing is that the progestin in it, especially if there is a androgen kind of reducing progestin or a testosterone lowering progestin such as drospirenone, will lower testosterone levels. So in patients who come in with low testosterone kind of symptoms, if they're on oral contraceptive pills, a lot of times what we'll see is that their sex hormone binding globulin level is very, very, very high. And then their testosterone level is very, very, very low because it's got that kind of 1-2 punch there on that. Now, other conditions that can affect testosterone, obviously, if you've, menopausal patients are typically going to have a lower amount of testosterone. Like we said, the gonads are the primary producer of the hormone. And so with the ovaries, producing that testosterone, if ovarian function starts to decline, whether that's through either kind of physiologic menopause or something like primary ovarian insufficiency or menopause before the age of 40, you're going to see a reduction in the amount of testosterone that's present as well. Now, there are obviously other medications that can affect that too. There's a medication called danazol that used to be used for endometriosis that lowers testosterone. Lupron is another medication that lowers testosterone. We use Lupron for endometriosis, for fibroids. You can also use it in some fertility treatments too. But it will lower testosterone levels. Really, there's a bunch of different things there. Spironolactone or aldactone is a very common medication that's prescribed for acne. And in doses higher than 100 milligrams, we do see a very strong anti-androgenic effect. And that's why it works for acne, because a lot of acne is derived from testosterone, because testosterone affects our sweat glands and our oil glands in our face and our body. And if it's high or if it's elevated, it will typically cause an overproduction of that, which leads then to more acne. So a lot of really interesting things here. Now, in terms of like I said, ways that we measure testosterone or ways that we, kind of look at it, if on the flip side, we have really high levels of testosterone, and I should say that there are really two types of testosterone we're typically looking at when we do a lab value, or this is something that if you're having this drawn, you want to talk to your provider about. Total testosterone is the total amount of testosterone that's produced in the body. So once again, from the gonads, from the adrenal glands, a little bit of peripheral conversion there. And that's what's there kind of overall. Free testosterone is the amount of testosterone that's left around after all of your kind of normal testosterone receptors have been plugged. And this is calculated based off of total testosterone with measuring sex hormone binding globulin, and you also look at albumin. Albumin is a type of protein that's in our bloodstream. And all of these things are kind of put together, and you kind of do this little formula, or your lab can do it for you, and you can calculate the free testosterone. So patients who have elevated free testosterone will often have those symptoms of high testosterone like I talked about, the facial hair and acne and things like that. The most common condition that we see in the United States that has this, especially in a gynecologic practice, would be polycystic ovarian syndrome, or PCOS. Now, PCOS, that's, when you look at some of the diagnostic criteria about that condition, and I talked about this a lot in my PCOS video, one of the main things is signs of either elevated testosterone from a clinical standpoint, so like the clinical features, or on a blood test. And so typically you want to see that free testosterone between 2 and 4, and so if you get a free testosterone that's like 8 or 9 or 20 or things like that, you have to be, saying, hey, what's going on? We really want to look at this. And this brings up a whole nother discussion about laboratory values and how a lot of providers look at just the lab range that the lab sets. And they say, oh, well, if it's not, out of that lab range, it's a normal value. And unfortunately, that's not really true. So I may talk about that in a future video sometime. But like I was saying, if they have really high levels of testosterone, especially if a patient's coming in and she says, or they say that, man, my periods are really off. I'm not, having normal menstruation. I'm growing kind of this facial hair. I'm having kind of cystic acne on my body, things like that. You really want to look for PCOS with that patient. The other thing that can definitely do that is kind of late onset congenital adrenal hyperplasia. That's another condition that really doesn't get a lot of attention. It's definitely more rare than PCOS, but it's still out there. And these patients have a lot of the same PCOS type symptoms, irregular periods, kind of the high testosterone. If they have insulin resistance, they may have more what's called centripetal obesity or centripetal weight gain, where that weight just kind of goes around your midsection. If you look at kind of the fruit analogies, it's more of kind of like an apple body shape as opposed to a pear shape. I don't know why we use fruit, but that's kind of what it is. Patients that have CAH will typically take those and then kind of move them to a little bit more of an extreme. And the way that we measure CAH is we look at also the presence of another type of hormone called DHEA S or DHEA sulfate. DHEA is dehydroepiandrosterone. That's a hormone that's produced in the adrenal glands that basically is a prohormone. It breaks down into both testosterone or androgens and then into estrogens, typically estrone, which is a type of estrogen that's often produced in menopause in high amounts. And DHEA sulfate is a kind of a weaker subset of that, but that is actually a measurement of kind of overall testosterone production and things along those lines. So a patient who has PCOS type symptoms or those type of irregular menses or ovulatory dysfunction, we'll call it that to be more specific, plus signs of hyperandrogenism. If they have an elevated DHES, the next thing you want to look at is another lab called the 17-hydroxyprogesterone. And this is a lab that's specifically elevated in patients that have congenital adrenal hyperplasia. So if that's up, boom, you've got your diagnosis and you save this patient a whole lot of headache, because if you treat them just like they have PCOS, well, they're not going to be taking care of the whole person. Now, congenital adrenal hyperplasia, like just that by itself, not the late onset, these are babies that are typically born with more ambiguous genitalia. And so if that's the case, you really want to do things like chromosome studies or imaging to really see kind of what's going on. And they often have a lot of other electrolyte anomalies, like they'll have difficulty metabolizing different salts and things like that. So anyway, other things that can cause elevated testosterone besides the two of those, kind of on a more dangerous side of things, are testosterone producing tumors. Now, typically these are much more rare, but can be found in patients of all ages. Sertoli Leydig cell tumors are probably the most common ones that we would see, common of the rares. And these will typically present with signs of what's called virilization. Now, virilization is different in that you have much more like facial hair and those high testosterone signs, but you'll also have voice deepening. You may notice an Adam's apple starting to kind of grow larger, and clitoromegaly or enlargement of the clitoris. And typically with virilization, that clitoral enlargement is very difficult to reverse. And sometimes it's permanent. You may have to have like a clitoral reduction surgery if you want to have that taken care of. So that's always something you want to look at too. If a patient comes in and they say, man, recently I've noticed my voice deepening, and I used to sing first soprano, now I sing, contralto. My clitoris is getting more enlarged. You really want to look for that, testosterone producing tumor there. So other things to kind of think about with, testosterone, or probably the most common question I get from other providers is, how do I prescribe this? What do I do? Well, the FDA in its, infinite wisdom does not believe that testosterone is a necessary hormone for women's health, which, like we said, is a complete fallacy. So currently there are no FDA-approved formulations of testosterone out there. So we have either two options. The first is to compound it, which, you get from a compounding pharmacy. The second is to take kind of like a male quote unquote FDA approved hormone and then put it into a quote unquote female dose. So for instance, if you were going to do a injection of testosterone cypionate, typically that's 200 milligrams per 1 milliliter of that medication, you would do 1/10 of that. So they'd be getting 20 milligrams per 1/10 of a milliliter. The ways that we do testosterone are kind of, we give it different methods. You've got a transdermal, like a cream or a patch. You've got an oral pill, you've got an injection, or you've got an implant. Now, oral testosterone it doesn't get absorbed well at all. Stomach acid really breaks that down. So for that reason, really, we don't recommend that. There's an old medication called Estratest, which is a mixture of both estrogen and testosterone that's not really FDA approved. It's got a really interesting story, but it doesn't work all that well. And oral estrogens have their own issues, like we've talked about kind of in the past with my estrogen video. Transdermal testosterone is by far the most, recommended, especially in women's health areas. And this is typically done by a weekly, a daily cream or a little kind of like underarm type gel, things like that. And the reason we like the transdermals is because you get a higher steady state more easily. With injectables, which is another type, you get a big implant, you get a big rise in that level, and then it starts to fall as that kind of wears off. And so you're doing, once again, this kind of like, game where this goes up, and then as it starts to fall, well, your next one goes up. And so you've got to try and do this kind of like, crossover dance move here to try and figure out when you need to do which injection and things like that. And so, the transdermals they just get up. And then since you're applying that every day, you're pretty much staying at that steady state. I have a lot of patients that come in who have had injectable testosterone or implantable testosterone, either from the form of like a pellet or other type of implant. These typically last around 3 months. Currently, there is no specialty society in terms of women's health that recommends the use of pellets because you really get into that super therapeutic level of testosterone, and that can lead to virilization, like I talked about. I've had ladies come in that have their total testosterone, which should be between like 25 and 40, and it'd be like 450. That's higher than my testosterone. And they're like, why is my hair falling out? And it's like, hey, there you go. That's what's going on. So I do not recommend pellets at all. Like I said, they have a lot of side effects and they're just very, very hard to monitor. So, honestly, I think we're kind of getting towards that, kind of 17-minute mark here on the video. So that's really a good kind of overall thing. I will say that in other parts of the world, they do have FDA-approved testosterone cream. In the UK, in Australia, I'm not sure about the UK, but in Australia, there's a medication called Androfem, which is actually approved by their version of the FDA or Food and Drug Administration. And so that's something, if you're in Australia or, you can actually get kind of a specific prescribing thing for Androfem. I have one. It's a little bit of a trick to get through, but you can definitely do that and prescribe that to, patients. Otherwise, that's about it for testosterone this week. It's really an interesting, hormone. And so it's something that, I think needs more addressing and really we want to focus on more kind of in the future. So obviously, if you have any questions, let me know. Otherwise, I'm Corey Babb, and I'll see you next week.